Well, thank you. It's a pleasure to be here today. I'd like to just start by saying that many patients would like to have their say and input when it comes to designing services which affects their treatment and their care. PCTs are well aware of the need to engage effectively when this comes to the redesign of care. So I'd like to just ask the question really, why then is this so fraught with difficulties, and why is effective engagement quite often between PCTs and patients not happening quite as we would like? Well, certainly looking at the main policy driver with Lord Darzi and the Darzi plans, I think I can speak on behalf of most of our patient groups, or all patient groups I should say, that we really welcome quality care for all, the patient-centred service, and having the care closer to home. But just let's have a look at the current state of play, and I would perhaps ask the question, are we doing a little too late? Because obviously the King's Fund report and the National Audit Office report show us that we really have a postcode lottery of service care for our patients at the moment. And I think given the current economic climate, we really do now have to look much smarter at how we're going to ensure that we deliver the right care for people with IA, because there doesn't appear to be any more money to be had. And a little bit of a look at the evidence. As a charity, we undertook a survey of PCTs in 2006, just to see how much patient involvement was actually taking place. And 35% of the PCTs that responded had not engaged with the voluntary sector, and some didn't know if they had or they hadn't. And when we looked at it again in 2007, 38% had engaged, 23% hadn't, and 39% still didn't know if they had or they hadn't. So some PCTs were obviously out there and doing a good job, but the picture was really quite varied. So really it shows that a significant proportion of PCTs are failing to put IA at the heart of their planning and commissioning and funding and provision of their healthcare service. And the picture in 2009, well, really, we don't think an awful lot has changed, and if you look at the results from the King's Fund report, which was published in January, and the National Audit Office report, which was published this July, it really is quite disappointing. It's not all down, of course, to PCTs not involving patients. There are other issues, and I just want to touch briefly on some of these. The 18-week target was a fantastic target of getting patients into treatment early, but there seems to be a whole issue around the whole ratio of the new to follow-up, because in many cases the whole bag of musculoskeletal disease has been put together, and the mean average taken to work out how often patients should be seen as a follow-up, and it really isn't appropriate for inflammatory arthritis, and particularly for rheumatoid arthritis. And as both of the King's Fund and the National Audit Office report show us, flare management has come out very badly managed in terms of patients not being able to get back into secondary care, and I think most of our patients are lucky if they get a review once a year with their consultant. Both of those reports also showed that there was quite a big lack of education across the board. Patients themselves don't understand the different types of arthritis and will quite often delay their own trip to the GP because maybe it's a bit of repetitive strain injury, they've done a bit too much work in the garden and so on. And GPs, on average, in the National Audit Office report, it takes 4 GP visits before patients will get referred to see their consultant. So this delay, given that we know there's a 12-week window of opportunity to treat this disease effectively and to try and really prevent the lack of damage across the joints, it is a shame that these patients are not getting the access that they need and quickly getting diagnosed. We've had many stories coming into the charity from consultants and from patients alike, where we know that commissioners, not in every case, but in a lot of cases, are not actually talking to frontline staff. They're talking to clinical directors around commissioning, but they're not necessarily talking to rheumatologists. And that quite often is leading to disfragmented services and patients just not getting the service they need because the disease is so complex. And PCTs are not adequately engaging with patients and the public, not in every case, but in a lot of cases. So we've decided as a charity that we really have to provide individual training to enable our patients to take control of their disease, and this is becoming increasingly important as self-management plans are now on the agenda and having a personalised budget. And it's important that patients understand what their rights are and what they actually need to know to make informed decisions. But the experience has been quite mixed across the piece, and we've had many people on the phone saying, well, I've said I'm going to join this PCT board or this PCT group, or Strategic Health Authority group, and they've sent me a whole pile of papers, and it's all in this NHS language. I don't understand it, and I just think this is way above me, and this has put quite a lot of people off when I think that really all that's needed is for somebody to actually give a very simple approach as to what is needed from the patient in these meetings. And often local politics can get in the way in localities around how you communicate properly when you've got patients sitting around the table. So we have undertaken these training sessions north and south of the country, and I'll go into what's actually provided the process and the structure for these training sessions in a moment. But we do believe that PCTs must take on board these lessons and provide adequate support to enable patients and the public to engage effectively. There's never been a better time to take inflammatory arthritis and rheumatoid arthritis now and to try and move it to the place it deserves in terms of patients getting the right treatment. The King's Fund report shows us this, the National Audit Office report does, and nice guidelines for adults with RA show us that we really have got quite a way to go from A to B to get to that gap of improving the service for patients with RA. The IA pathway for commissioners, which the Department of Health has endorsed, is a marvellous piece of equipment to use to make sure that patients are getting the right service commissioned for them. And at NRAS we are going to overlay that with a patient pathway so that patients really are aware of what is out there for them when it comes to looking at the right service that they need. And what are we doing about this as a charity? Well, back in January of this year, I met with Lord Darcy, and this was as a result of a meeting with some members of the Health Select Committee in Parliament. And we were looking at the low priority given to rheumatoid arthritis in relation to diseases like CHD, cancer, COPD, etc. And given that rheumatoid arthritis is life-threatening and that it does have a very high risk factor of cardiovascular disease, we felt it should be given as high a profile as diabetes and CHD. And of course we want the implementation of the NICE guidelines and the IA pathway. So all this was discussed with Lord Darcy, and his suggestion to me was that I actually go and see the medical directors at the Strategic Health Authorities and ask them what their long-term conditions boards would be doing in relation to this. I've had some very interesting meetings and some interesting responses, and I have to say on the whole they've been very positive, and this has been really helpful, but we just need to make sure now that all of this good stuff gets implemented, and that's going to be quite tricky. And in order for us as a charity to understand, it's no good just looking at the top-down approach. We really need to look at what's happening on the ground and understand how our NHS organisations are implementing and prioritising the national policy. So I took the decision to actively get involved in my local SHA at the East of England, who I have to say are doing a fantastic job involving patients. It is an outlier. There's a big report that was done looking at the different priorities that health authorities were placing, and East of England is an outlier in terms of involving patients, which is fantastic for us. I'd just like to see it happening everywhere else. But I've got involved with their long-term conditions board, with their clinical leadership board, and their patient experience board, and I'm using that as a basis to mentor our members in terms of the NHS training that we've given them across the north and south. And I'm also involved in the local links network in Cambridgeshire, so for our members they've got that sort of experience to call on to get themselves involved in their own localities within these different organisations. So we have a big commitment to this, and all of the activities that I've discussed today show that as an organisation we're very well placed to mentor and advise our members and healthcare professionals in how to work with their local NHS organisations in terms of obtaining quality services for RA provision.